Hi everyone, good morning and welcome to day two of the International Rare Disease Showcase. Lovely to see you all and thank you all for joining so much. I'm just going to start off by saying a quick thank you to all of our sponsors. Without these, we wouldn't be able to put on this event today. So thank you to our corporate sponsor, Helix, to our gold sponsors, Pulse InfoFrame, Bionicle, and Apparito, to our silver sponsor, Use of Pharma, and our bronze sponsors. So we've got Gilead, PTC Therapeutics, Roche, and Rhythm. And thank you to the Community Fund also for supporting us. So wouldn't be able to put on the event without them. So I thought I'd mention them first. Okay, welcome to our first main stage session of today. It's a panel session on building the rare communities of Africa. I'm Hannah, for those of you that don't know me. I'm the project's officer here at Beacon. Also joining me as a host is Rick, our CEO. I'm sure you've seen him around already. And we also have Shirene Badger, a patient advocacy lead at Illumina, and she will actually be hosting the main panel section of this session. Okay, so why have we chosen to do this session? So when looking into rare diseases, it's easy to focus on the major Western markets and overlook the progress in other regions. However, the recent African Summit on Rare Diseases has highlighted the growing movement in Africa, and we really wanted to use this opportunity to look at what's going on in the continent and to address the distinct challenges that their rare disease patients face. So we're joined by patient group leaders from South Africa, Kenya, Ghana, and Zimbabwe here with us today, and Charlene will introduce them really soon. And they'll all be discussing their experiences building a rare community in their own country. They'll also be looking at the successes and challenges they've faced on this journey, and also the differences and commonalities within the continent and the rest of the world. So you see all of our panelists here. So now I'm going to pass over to Shirene from Illumina, who will be, like I said, chairing the session. Hi, Shirene. Thank you for joining us.
Hi, Hannah. Thank you so much. And I just want to start with an enormous thank you to Beacon. I'm going to get used to calling you Beacon. I love the name and I love the transition that you're making and all that Beacon represents. But also, I want to say a huge thank you for this event because Rick, you and the team know that for me, the showcase events have been instrumental in facilitating so many of the relationships that I hold really, really close, and a lot of the lessons that I have learned in this space over the years. I think this is an extraordinary network, and I want to say thank you for all that you and your team are doing and will be doing as you go forward. So thank you for that. As a further introduction, I just want to say personally, this is an enormous honor for me. And I want to say that I don't necessarily feel like I'm the right person to be doing this, but the people who are on this panel are hugely important to me. And while the introduction has said that in some ways we overlook progress that is happening elsewhere, I guess what I'm most excited about by this panel is that each of the people on this panel have challenged my notion of what it means to do patient advocacy in the rare disease space. I think that we can't see it as overlooking what's happening in Africa. What is happening in Africa is phenomenal, and I think you will come to see that as we continue this discussion. So it's an enormous honor for me to be here and to be talking to this group of people. I'm going to ask them to all put on their cameras because how we are going to do this session is going to be a discussion. We are going to talk about the African approach for Africans, by Africans. We are going to talk about how we own our own narratives. And how we are not waiting for other people to do this for us, how we want to build sustainable practice for our rare disease people in our African countries and also as a group across the continent. So as was highlighted, there has been a recent summit and many of us have been talking quite a lot even before that. But what we're going to do is start with really brief introductions. And I'm going to let everyone introduce themselves. Just key, could you say where you're from, maybe one key thing about yourself, and then we'll move on to our discussion as we go forward. So Trudy, do you want to start? Thank you.
Thank you very much. Thank you for this platform. Thank you, Beacon, and everybody else who's made it possible. My name is Trudy Nyakambangwe, a very long surname. I am from Zimbabwe, and I'm a hemophilia carrier. I'm also the director of an organization that is working towards supporting people living with rare diseases more. Thank you.
Thank you, Trudy. And I look forward to hearing some stories because you have some incredibly powerful stories to share. Kelly, we've already met you, I think, in this meeting, but I'll let you introduce yourself again. Thanks.
Thanks so much, Shirley. And I'm Kelly du Plessis. I'm the founder and CEO of Rare Diseases South Africa, and really, really passionate about patient advocacy. Came into this community at the diagnosis of my own child with a rare condition, and really are looking forward to some fruitful discussion today. So thanks.
Thanks, Kelly. So Christine and Rosalind are from Kenya, but I'm going to let you introduce yourselves individually because you often get paired up together. But Rosalind, can you start? Thank you.
Thank you, Charlene. I'm Rosalind Odero from Kenya, Nairobi. I came into this through my son, who's 5 years old with Joubert syndrome. And I work with Christine with Rare Disorders Kenya.
Christine Mutena is my name. I'm a mother to 2 kids with different rare conditions, and I co-founded Rare Disorders Kenya with Rosalind, and together we are hoping to make the future different for our children.
Thank you, Christine, and we look forward to hearing more of your stories too. And Samuel, last but not least, because you're a bit of a mover and shaker at the moment, and many of us have possibly heard you already, but Samuel, can you introduce yourself now? Thank you.
Good morning, and thank you for, can you hear me? Yes, good morning. Thank you for the opportunity. I want to thank the organizers for creating that platform for us to meet again. I'm seeing amazing people here, my colleague advocates in Africa, and I'm glad to connect once again after a long while. And yeah, my name is Samuel Riafe, and I'm a clinical psychologist and the founder and executive director for Rare Disease Ghana Initiative. I came into the rare disease advocacy efforts to help patients who live with rare diseases, syndromes that were unknown as well, that had come to me for care, and trying to find a way to help them brought me the advocacy space, and I've been doing this since 2017.
Thank you, Samuel. So we'll hear more from each of you as we continue. So I should just let the audience know that we've had a number of conversations, and we've talked about what we want to share with you as an audience today, and we have some themes that we want to start with. And I'm going to direct this back to you, Samuel, because one of the things that we talked about initially, if you could kick this off, was what are the issues that we are confronting across the continent, but also at the national level, and how can we express this to this audience in terms of the very real and pragmatic issues? And one of the things that you raised, and I want you to maybe start talking about this a little bit, is that notion of what is a rare disease, of even defining a rare disease, which I know, Kelly, you can talk about in terms of the work you've been doing on a definition. How do we get a definition for rare disease? But just this work, and we talked about this the other day, of belief. How do we deal with the fact that, are we actually making rare diseases up? How do we prove and create evidence that rare diseases exist? And I guess some of this starts with diagnosis. How on earth do we access diagnosis, and what is the diagnosis stories that you can share? So Samuel, can I just ask you to start on that, if you wouldn't mind?
Yes, thank you very much, Shirene. Thank you for the opportunity once again. For many African countries, we've been made to believe that the conditions that affect us are usually the infectious diseases. Those are the diseases that are killing us, and so many non-communicable diseases or genetic diseases, we do not. It's not really talked about, or is treated as a familiar, unfamiliar. It doesn't exist in our setting. And so, and because we are not directing efforts in our attention in being able to even resolve the common non-communicable diseases, we're talking about hypertension, diabetes, and even common non-communicable diseases. Having to talk about rare disease seems like something that is very, very far, and makes it very, very difficult for people to even believe that diseases which are rare in nature and usually of genetic origin do exist. And I've had many instances where people who you expect to know would even ask you questions about if rare diseases do really exist in Africa. These not diseases that affect the West and people in other parts of the world. We believe these diseases are diseases that is it not coming from the new food we are eating and the lifestyle changes we are making, and these are some of the questions you get when you have to talk about rare diseases. And I remember one of the days he was speaking in one of the offices, highly respected office, who have power to change something. Then the head of the institution says, "Oh, what is rare disease? Are these people not just creating terms and just to disturb our lives with?" And so there's even coming to accept that there are rare diseases. It's something that is not easy to get people to accept and believe that rare diseases exist in our heart.
And I'm seeing lots of nods. Who would like to share more on that? Because, okay, Kelly, please.
Sorry, I have no idea. It sounded like I was in a train station there for a second. From my perspective, I think just to add to what Samuel was saying, I actually think we probably have a higher propensity of and a higher prevalence of rare conditions in low and middle income countries for a variety of reasons. One, medical termination is not offered very often due to cultural reasons. Two, we have lack of education and awareness around prenatal testing, diagnostics in utero, etc., are not necessarily available. And you also have, we've often seen a family who have 3, 4, 5 children, all impacted by the same condition because of the fact that the diagnostics and education and testing opportunities haven't been made available. So, I mean, really, it really is debunking the myth that these are Western-based conditions and, we simply aren't impacted by them. I think one of the challenges is that often people don't get to know about the African patients that are impacted. And that's essentially why conversations like this are so important.
And leading on to that, I think, you've raised 3 incredible points there, but I also think that this is an important point that you and I have discussed, Kelly, about just actually getting people in front of the right people for people to get a diagnosis too. So it's a matter of the systems, it's a matter of a whole lot of things. But the other thing that we've talked about too is genomic diversity. So you've said that actually you think that it's possibly more. And what we know from some of the research that is coming out is that we don't actually have a reference. Our reference system in the rare disease space is still predominantly white European, and we need to challenge that as well. Does anyone want to speak to that a little bit or say anything to that point?
Yeah, definitely. Okay. Christine, you can touch on that.
No, I was just going to add on to what Shirene is saying about even when it comes to clinical trials, you find that most of these trials are done they're geographically based, if I can put it that way. And when it comes to the where when the medicine's already been created and they come to Africa, they don't work. So I think we just need, as you said earlier in the opening of the conversation, is we need to have a discussion around Africa by Africans for Africans. And this just basically is from the whole spectrum of rare diseases, up to the whole health spectrum, but in our case, it's rare diseases.
Yeah, Trudy.
You're on mute, Trudy.
I just want to paint a picture of the hardships that rare disease patients in one consulting day, okay? I know it takes 4 to 5 years for a patient to get a diagnosis, but I'm not going to even go there. I'm just talking about one day. So someone sees or notices that there's something wrong with their child. They travel from a rural community very early in the morning with the first bus that gets them into the city and gets them to the hospital. They get there, they wait 3-4 hours to see a doctor. They eventually do get the doctor. The doctor will tell them, we suspect you've got this condition. You need to get tests done. And these tests, some of them are available here, some are not. So they get some tests done, then they have to travel to another private lab to get other tests done. Once they get to that lab, they are told only half of what you've brought can be done here. The rest will have to send for Zimbabwe, it will probably be to South Africa or to the UK. And so half the tests are done, and then the rest, they can't get them done because they've run out of money as well, because it's extremely expensive. So now that they also have a prescription, because they were told this might just help things out while we wait for the tests to come in. Where am I getting this medication? Not in the state hospital, which is where most of our people go. They have to go to a private pharmacy, and they don't want to stock rare disease condition medication because it's just for a few people. So they run around like headless chicken all day, trying to get a pharmacy that has what is on their prescription. Sometimes by the time they get it, it's end of day and they can't go back to their rural home. And they don't know anyone here in the city. They sleep over by just sleeping in verandas outside to wait for the next day. They collect medication and go back. And they're told they have to come back. And this goes on for years. This is challenging and frustrating and depressing. And in most cases, parents end up giving up. And I think that's where we come in to keep them going until they get something that helps their child.
Yes, so basically you could see that what we have basically been talking about is basically an issue of a lack of opportunity and lack of access to be able to even arrive at a diagnosis. And if we are not able to diagnose, then you are not able to report. And then if you're not able to report, then there isn't enough data that will help to inform decision regarding the care for the patient at the policy level. If you're not able to diagnose too, then you are not able to treat or look for what support or services may be available or useful to the patient. And because we are not able to diagnose too, then the family does not have information enough to decide on what to do next in terms of their life. And when that happens in a culture where we do not accept difference, let me put it that way, it's just difficult for people to accept difference. Having a child with a rare disease and we don't even know what disease it is, the family are hopeful that they would have another child who their hope is they will have a child who, quote unquote, is defined as normal. And they give birth to another child with a similar condition. And then instead of people helping to see what is wrong, we'll now begin to ascribe meanings into why this family has same children with different disabilities, they begin to ascribe spiritual meaning, or as if the family is cursed, or this is a typical everyday system that is going, and it all starts from the basic lack of opportunity to even diagnose that family who might have a rare disease, and that is one of the realities of how things are from our part.
And you know, we've talked a lot about all these different stories and the very, you know, the individual cases, even in terms of how do we get people to the right people, how do we even help people come out of hiding, even to seek appropriate care. Christine, I saw that you had your hand up, but can I drop to you first, and then we'll move this on a little bit more too. Thank you, Christine.
I was going to add to what both Trudy and Samuel are talking about. Also, you find that in that same case scenario, the parent will give up in terms of taking the child for care, because are they going to keep spending money going to the main city to get drugs for that one child, and they have like maybe 5 other children to fend for? So it becomes a balance, a moral decision. They have to decide, who am I going to fend for? The 5 that are okay and they can get food for them, or the one that is ill and they can't get medicine for?
And that's a really, I guess what you've talked about too is, you know, the very complex kind of circular notion. It's kind of a lose-lose situation, and how do we change that? How do we push the dial to make a trajectory like we talk about over here? And Anna yesterday presented on the Rare 2030 Foresight study, and kind of the journey that people go through. And so, you know, one of the things that I know we're talking about a lot is how can we start to put in things in place that move that into a journey that actually progresses. Now, I guess there's been a few questions about awareness, but Callie, I know that you've done a lot of work around just building a rare disease definition, and then also maybe the others we can be thinking, because we've all been talking too about databases, you know, the need for data, the need for getting diagnosis so that we can start to create data, so that we can start to build the evidence to start to raise awareness and all those sorts of things. So Callie, can I turn to you first, and then to the others? Thank you.
Yeah, I think if I can, Shirene, just to touch on the first issue of data and how vitally important that is. And it's kind of a catch-22, like what comes first, chicken or the egg situation, because you want to advocate, you want to raise awareness to find new patients, but you also don't want to find new patients without having solutions for them. And then from an advocacy perspective, you want to be able to go to government and say to them, we need to do something, but you need the numbers to be able to justify needing to do something for them. So, I mean, we find ourselves on this continuous wheel of, you know, trying to cover one end essentially to further the next, but they're dependent on each other. One of the things that we've recently done is the development of a patient-led registry. So one of the big issues that we find in South Africa is that there's a reliance on clinicians to actually, you know, participate in any sort of formalized data surveillance initiatives. And unfortunately, they're completely overwhelmed and don't have the capacity to do it. So there might be a passion and a willingness from their side, but it comes down to resources and time. So unless there's a dedicated nurse assigned to doing the surveillance, it doesn't get done. So we've now tried to find a way to take the responsibility off the clinicians and put it in at the heart of the patient, and let the patient submit and actually register and sign on, and then merely have a clinician confirm. And we're hoping we'll only launch at the end of this month on Rare Disease Day, but we're hoping that with that, we would have actually overcome one of the massive issues, and then we can drive advocacy better.
And Trudy, yeah, do you want to talk to that point? Because I know that's important for you as well.
Yes, it is. It's really important for us because Zimbabwe geographically is a small country. So we have a small population, which means our rare disease patients are even fewer. So we are dealing with very small numbers, which are very difficult to go with and negotiate for better services for. So I think the issue of data, when we say many is more, when we have different rare diseases, but small numbers for each rare disease patient group, it makes it very challenging. So we would like to try and then put our work together so that the numbers become more meaningful. And I'm glad that Kelly mentioned that, because I thought their task was easier because they have more patients. So I think the struggle does continue for all of us. Yeah.
Yeah, and I know that having a definition and having a database, because data is such a big issue as well, isn't it? In terms of and this gets back to our opening in terms of advocacy in Africa for Africans by Africans, is making sure that we keep hold of the value that we have within our countries and within our continent, and that it doesn't get exploited as well, and that we don't run risks with trust and all those sorts of ongoing issues that we know have been have a legacy and within the continent. So I know that those are things that are all really important to you, and I guess I want to move this up because we've painted a really clear picture of the difficulties, that actually this is just hard work, and a lot of people will be sitting there going, like, where do you start? Like, the chicken and the egg, what pieces do you take off first and chew first, and how do we move things forward? And I'm aware that there's been a question in the chat about is this about awareness, or is this about lack of coverage about rare diseases in African countries? I'm wondering if we can start to talk about that a little bit, because in terms of the steps that you're taking, how are we moving this forward? How are we building awareness, and what do you because I'm so inspired by all of what you do, and I think I want to show that this is, while the problems might seem like huge mountains, that actually all of you are climbing really high up that mountain. So Christine, Rosalind, can I turn to you first?
Let me leave it to Rosalind.
Okay. I think for us, we started first of all by, constantly going to the government, because from policy, you can be able to move into the whole idea of awareness to the whole country. Yes, we'll make our own noises to just get people to understand what rare diseases are. And I remember the first meeting, we went to the Ministry of Health, and they're like, what are you guys talking about? Are you talking about neglected tropical diseases? So we had to start informing them first. And then with that, continue conversations until where we are right now. And we are at the point that they formed a technical working group for the first time in Kenya to address rare diseases. So that working with the government, we will get somewhere. But as much as we continue making our own, building awareness, and then of course the issue of registry, where will it be hosted? Is it going to be the government? So those are the conversations we get challenged. Have challenges with. Yeah. Christine, you want to add?
As Shirene was saying, we have challenges, but we have milestones. And that is what keeps us going, in the sense that we started rare disease, 2014, Rosen, right? And look at us now, the Ministry of Health has acknowledged that, yes, wait, there are rare diseases. So whatever happens, the ball has started rolling, and that's enough for us. And I think that's our take home for now, as much as the journey ahead is long, we have started a journey.
Yeah. Yeah.
Kelly, do you want to add to that, awareness raising, the work that you're doing? Because I know that you're very clear in terms of talking about rare is everywhere.
Yeah. So I think awareness forms a vital part of everything that we do. And it's vitally important to, when raising awareness, do it in a way that's suitable to your local geographical representation. I think one of the key mistakes that a lot of organizations make initially, nascent organizations who are just starting, is to almost try adopt previous messaging that's been developed by other countries. And unfortunately for a lot of us, that reference point is very, very often European as well. And we speak our own language and we have our own culture here. And it's very, very important to advocate in a way that is relatable to the policymakers that you are approaching. And so I think that that's been one of the learning insights for us in terms of our advocacy.
Mm-hmm.
Really important points there, I think. And Trudy, I know you want to add there. I really think that's important too, in terms of, because I know we'll talk in a minute, and maybe if I go to Trudy and then Samuel, but we talk about the coming together of these organisations across the continent, but at the same time being very aware that the national needs are still very diverse as well, and very distinct populations, very distinct cultures, different languages, all those sorts of things. Really, really important that we consider that and don't just apply things that have worked elsewhere might not work. And how do we decipher that? So Trudy, thank you.
Yeah, I think it's a process. And when you have other patient advocates to learn from, then you can say, okay, they made that mistake, so we aren't going to go that way. But what I also realized is that when we started, we thought, oh, let's do a national thing. Let's go big. Let's go to the ministry. Let's go to big bodies. And we were really frustrated because of that move. And then we came back and sat down back to the drawing board and realized that our work is probably grassroots. Let's find the families that need this and try and just support them one family at a time. And the recognition will come once we have done some work and there's evidence that something has been done around rare diseases, than just to talk from Norway to say, because there's rare disease South Africa, there's rare disease Ghana, so we also want rare disease Zimbabwe. So no, that doesn't really work. Each country, I think, has its own pathway. Yeah.
And, I think that's so important, one family at a time. I think all of us in advocacy know that as a reality, that actually we have starting points. We go from the micro to the macro. We go from individuals to the collective constantly. And isn't that what the mantra rare as many is all about? That actually individually rare, but collectively common. So it's this movement between the two is so vital. Samuel, can I let you step in now?
Yes, a few comments. I didn't get to comment on those. That one was Christine raised an issue of moral issue on the side of the parents, and I wanted to share my own experience as well, dealing with policymakers. And one of the questions I get is, okay, Samuel, so you have if you are assuming you are the government and you have 10,000 cedis to spare, and if you have this 10,000 can save one patient, versus this same 10,000 can save like 100 patients with dying from malaria, where will you push this money to? And that was a really big question that was pushed to me, and so I realized I think I gave them the answer they need, and I also try to bring them to understand the economic impact of not taking care of the rare disease community, how much it will mean, how much the government is also. So we spoke about how much the economy loses rather for not. So you are looking at how much you have, but you are losing more. So why won't you try to save on taking care of the rare disease community by giving an assumption? Sometimes we face these ethical dilemmas at the policy side, where policymakers have to take those decisions. That's why the data is very, very important. That's why I agree with Kelly and Trudy, Christine, everyone. We equally started work on data at a very early stages of our work, in understanding the impact data can be. But specifically on awareness creation, I think that for us, we look at the whole ecosystem of the rare disease care. It is not one person to make a decision when it comes to rare diseases. it is a multi-stakeholder decision that has to happen at the same time if we want things to change. And so that influence our engagements from, you need the patients, you need them to share their story for the policymakers to understand, you need the industry to be willing to expand access and be ready to make available products and even develop products. You need the clinicians to be ready to see patients, to not just ready to see patients, but even willing to upgrade their skills to be able to adequately manage the patients. You need the researchers to do the research. So it's a whole ecosystem. You need the funders to fund. And so you need, for us, that influence our awareness creation approach by making sure that we are targeting pieces of the cake, each person, bringing each person on the board at every point in time. And that has been our model to keep rallying everybody along in the awareness creation strategy, not focusing on one side, because if you create awareness, you do public awareness, and there are many patients reaching out to your organization, and as Kelly said, you cannot help them, then what did you do? And so you need to also mobilize resources. You need to reach out to funders and get some funding available, some resources available to sustain the care. So that has been the model. We wouldn't say the problem of rare disease in Africa is mainly the lack of awareness. I think it's multifaceted. It's multifaceted. But the biggest one that I have seen is the basic lack of opportunities. Even organizations working in Africa don't have the same opportunity as organizations working in rare diseases in the West have, and they are able to do more, and even organizations in Africa have viable projects and they are not able to get the funding they need and the resources needed to do. But as Christine said, we've started, and many of us here are doing their job. They're very committed to their job, and we don't look at the obstacles. We look at being able to solve the daily problems presented to us by the community. And that has been our motivation, making sure that every patient is served and our continent is equally represented, and have some model that works for us. And we believe that it's hard time other organizations come down to learn from us too.
Thank you, Samuel. And I think you've touched on so many things that I want to bring back. And one of the things that I've learned from you all really is your whole ecosystem approaches. And I guess that gets back to my last summary about the movement between the individual and the collective, between the patient and the system, and recognizing one of the things that I think you all do incredibly well is recognize the multifaceted nature of rare disease. And perhaps it's a really pragmatic, that actually you're confronted by it, so you have to acknowledge the whole systems in some ways. But I wanted to bring this up because I think that's a nice segue into this really, the way that, and I do want to just say I love that you said we're all doing our job, because you do, and we'll get back to that, I think, before the end, in terms of the way that you do your job and the way you do advocacy, because it is something that I think everyone needs to listen to and learn from, because it's unique, it's exemplary, and it solves a problem. So we'll get back to that later. But if we can talk about this multifaceted nature and the whole ecosystem, one of the things that we have talked about, and I don't want to go back to challenges, but I do want to talk about how do we work with the systems, because we understand that the systems are very complicated. They're sometimes quite infantile in terms of the way that they are developed at the moment, that there can be non-existent systems, non-existent policies. Again, I know that you all have examples of what you're doing in this space. Who would like to start by starting to talk about, healthcare systems and how we do advocacy from the individual to the system?
I don't know if I can start.
Of course you can, Samuel.
Because I'm the clinician and I would deal with the healthcare system every day. But I think that because many of the systems are just developing, and until recently, you wouldn't hear people talk about genetic testing and even it being available at the hospital level. And so it happens to be part of our job, not just to focus on just the awareness, but also to be able to provide the tools that are needed. Or it's not enough to tell a doctor to do genetic testing when you don't know where to get it. You need to also be able to have the roadmap and to direct them on where they can get it. And so this is how, and so I think that the approach should be that you should have also some roadmap that directs or shows. So if you're telling the ministry to have a policy, you should have probably read a policy that you liked and would want to see it being implemented in your country. And then you can tell the ministry that, okay, I saw these people's policy and I think it's good. And if we can look at it, it may be helpful. If you're looking to tell your clinicians to upgrade their knowledge, then you need to have resources. You need to know where they can get their trainings. You need to be able to show the way. That is the key issue with doing advocacy in a system that's very infantile. Secondly, you need to have a very collaborative mind. The mind has to be very open to collaboration because the whole ecosystem that you're going to work with. And so you need to be very, very open and very ready to collaborate. It may not be as you want, but it still may be some level of collaboration. Yes, so thank you.
Thanks, Samuel. Christine, you've got your hand up.
Yeah, I'm not sure if it was from Tanya yesterday, or I'm not sure which speaker said yesterday, but what she said was, in rare diseases, we cannot have competition. We cannot say this patient is mine, that patient is yours, or this end of the, these stakeholders decide this half is working together against the other half. So I think if we all agree that we're all working for the betterment of our patients living with rare diseases, regardless of what end of the community you're coming from, we can go places.
Totally agree. Kelly, go.
Yeah, I was going to say, if I can add in a little bit. So there's two elements for me. One, I think, is educating students when they're still at medical level. That's when their brains are still fresh and their minds are still open to new ideas. And we need to harness that energy. I think it's a lot easier to convince someone that rare diseases do exist and get them interested and keenly looking for things at that stage than it is to take someone who's been clinically in practice for 40 years and has a specific way of doing things. So I think that that's one opportunity that we often miss. The second is with regards to, clinical care and sort of bedside care. And I always think, unfortunately, rare diseases are not the sort of conditions where you can be 100% confident that your doctor is going to have a ton of knowledge. Nobody is impacted more by the knowledge that they need to have than the patient. And there's almost a reluctance in healthcare to give patients medical information because there's this concern on how they're going to use it, right? But let's be honest, Google's kind of elaborate, it's kind of like knocked the barriers out the way there. So patients are accessing this information irrelevant. They are able to get their hands on it. Why are we not giving it to them in a mechanism that empowers them and allows them to be knowledgeable, that they can be not on equal footing to their clinician, but they have enough ability to be able to self-advocate and to bring things that they know to be relevant based on their research, etc., to the clinician's attention. Because we have all the time in the world to research our conditions because it impacts our life and death, or the life and death of our loved ones. So no one's going to tell you more about the upcoming research on the conditions that impact us than us. However, there's still this I don't know if it's ego, if it's hierarchy, if it's, this historical way where patients come to the doctor for an opinion. That's not the case anymore. We come to doctors now for ratification. We've already developed our opinion. We're asking you to confirm that we're on the right road. And the reality is that if your clinician doesn't, you move along and find one that does. That's how it is now. So let's rather work towards a common consensus. We're all in it to win it, essentially. And I think if we can break down those barriers, I think it will really, really help the clinicians and the patient's respective roles in the ecosystem.
So, Kelly, you've segued us into the issue of self-advocacy, and I think that's something that we'll come back to in a little while. Rosalind, I know that you wanted to say something first, and I'm not sure if that's on system, so we can, if we talk about that, and then, yeah, great.
It is. I wanted to say one of the other ways that, like, for me, how I reach out to, like, just to advocate to the system is like, I find, like, I start with the doctors that see my son. At some point, we had like 7 specialists. So with those ones, and then you build on from there. So whenever we have these webinars on rare diseases, specific, let's say, for example, Dravet syndrome, whenever there's that, I will send it to my neurologist, my son's neurologist, and ask her if she can send it to hers. And an interesting conversation yesterday, I was talking to a gastroenterologist, and she saw this particular webinar, and she was actually interested, and she was like, can I send this to everyone else? And with that, shortly they gain the knowledge. Then they are able to, at least when they see a disease like Gaucher, they are able to recognize and even know what to do. The other thing is, like, Samuel talked about collaboration. For example, we don't have newborn screening, and it's something that would really help at the very minimum for diseases like sickle cell that are a bit more rampant in this region. So we are trying, I know right now there's a pilot or something coming up that is for newborn screening for sickle cell. So we push for that because our end game is also for us, where we have diseases like PKU, phenylketonuria, and among others. So working with others, we push there, we get a foot in the door as we work on getting, towards that. So it's a long journey. But yeah, that's one of the ways that it can work for some of our systems.
And I think you've raised really great points there too, in terms of recognizing the need for collaboration. And sometimes that might not seem quite so obvious in the first step, but it's the long game there. It's kind of, okay, if this opens the door a little, then this will move the dial later on. And I think that's really important. So I just wanted to go back to, we've talked about diagnosis, we've talked about lots of things, and I know there's been a comment or a question on the chat. So Medics for Rare Diseases are here, and they're wondering to what extent they can support in terms of developing education that might help with medical doctors across the continent. But I also know that you are all heavily involved in that education work. From the example you've just given, Rosalind, of the just giving someone a webinar, that individual contact with medical practitioners, right through to, I know that you do a lot of education work, Samuel, in Ghana. And Kelly, I know that your story started with your diagnosis, and that you felt like, at the very least, I could educate medical receptionists on some etiquette as well. And it's just, about how you even give a diagnosis. And I know that what I love about all those examples is that medical education for you within each country is not just one thing. It's multifaceted. It's one-on-one communication, sharing of webinars, sharing of information, through to the education events, through to just how do we communicate about these things in an appropriate way? Does anyone want to just pitch in on that before we move on to the self-advocacy piece as well? Because I think, what this shows us too is that advocacy is not just one thing. Education's not just one thing. Awareness is not just one thing. Like rare diseases are not just one thing. It's like it's take those opportunities when you can. Samuel. Okay, Christine. No, go, sorry, Christine.
Okay. Patient advocacy and patient voice is actually becoming very strong in the medical field, both globally and also coming back to Africa. And I think if we piggyback on that movement, that patients should be on the table as much as clinicians around the table, as what Kelly said earlier, not a top-down approach about where you go take this medicine and I go home and I'm like, what is this medicine for? So if awareness is done mostly on the medical fraternity end, in terms of accept that patient voice is key in diagnosis, in management, in treatment, because even if like for a common cold, I go to the doctor and they give me, or malaria and they give me medicine and I don't believe in that medicine, I will not take it. So you see, we need to be in tandem together. We need to agree that this is for our collective gain. And from there, I think we can move mountains.
Samuel. Thank you, Christine. Agree.
Yeah, so I wanted to say that from what I get, we are looking for a very collaborative healthcare system, which is patient-centric and attends to the needs of the patient, being very friendly and soft, like a model that is changing from the orthodox or the traditional way of delivering healthcare, which we are used to infectious disease. So patients has an infection, we have to quarantine, treat, and no, but like these are rare disease, people's life, their livelihood, it's their life, and it's so we need to look beyond the condition and be able to think of a system that addresses all their needs together, and that is a kind of healthcare that we are from my angle we push for, in terms of a model that it's not centered on people sitting in some office taking decisions and neglect the voice of the patient who is receiving the care in the first place.
And, you know, I think that's a really important point, because I think sometimes when we talk about working within the healthcare systems, we talk about working within healthcare systems and not changing that system, or, you know, just making it work for us. And sometimes that's, you know, that's the first step. That's what we need to do, is just make it work for us in the first instance. But what I think each of you have always taught me too is that there's a vision not only here for individuals and families with rare disease and the collective community. There's a vision here for what health can look like and how it is practiced. And I think that's what you're getting at, Samuel, isn't it? That actually, in case by case, what we're doing is changing the system each time in the way that we do it. Does anyone else want to add anything to that? No. So it might lead on quite nicely, because one of the things that we have talked about a lot is, you know, Kelly, you touched on this in terms of Google, that we know that an empowered patient has better outcomes, all those sorts of things. And I know that we hear story after story too, where people might get a diagnosis inappropriately, and the first thing they do is jump on Google and then end up hearing horrendous. And I know that was part of your story too, Kelly. One of the things that I think is really important here is, we talk about self-advocacy a lot, but often we don't actually know what that means, or we don't know what it looks like. Yet what I see in each of you is something that really pushes self-advocacy to another level. And I just wondered if you wanted to share a little bit of your vision for how we change these healthcare systems, how we, you know, move these mountains through empowering our patients to advocate for themselves.
Yeah, so this is something I'm very passionate about, because I think we created monsters in our own way. In the beginning, when we started Rare Diseases South Africa, because of my own journey and my need to want to help everybody and make it easier for them, I did everything for everyone. And in actual fact, it was the biggest mistake, and it was in respect to the patient, because the best way for a patient to receive the outcomes that they need is for them to work towards it. And patients have responsibilities. I think it's easy to blame or to lay the responsibility at the feet of your pharmacist, your physician, your clinical team, etc., etc. They're not going to do the work for you. They don't live with the pain every day. They don't live with the inconvenience, the financial strain, the burden, the emotional impact, etc. So it's important for patients to learn from the very beginning how to self-advocate. And I think as patient organizations, we need to be careful of that fine line between empowering and enabling. And it sounds harsh. And, it is a harsh statement to make, but I make it with 6 years of enabling. And at the end of the day, I hadn't actually done anything to help patients learn to advocate for themselves. So I've had to take a really hard look at the way we do things. So that's very, very important. And patients need to learn to find their own voice. It might be a squeak in the beginning. It might be quiet, but it will eventually turn into a roar.
Okay, can I talk now? Yes, to add on to what Kelly is saying, something else that we've realized is that if we do not empower our members, if not empower the community we represent, we as an organization will not move forward. We cannot focus on policy if we are empowering/enabling our members. We need to help make sure they reach to a point where we started is where they should get. Then they leave us to go and create policies in place. Because as I said earlier, both policy making and patient empowerment have to go together so that at least they can meet ahead. So I think it is critical and imperative that we learn to empower our members. And on that note, they know there's a parallel session on individual advocacy. Please go back and watch it, because I think that is key for this conversation. Thank you.
Thank you, Christine. Thank you, Kelly. Samuel.
Yes, I need to make this quick. We have blackout, so my laptop may go off. And so I think that I agree with Kelly and Christine. I mean, as a psychologist, I believed that the patient needs to be empowered to speak for themselves rather than you speaking for them, because then they are not assertive enough. And so I think that for us, that has been part of our model. We always encourage patients to talk to their clinicians, we don't do the talking. Though we have a care coordination program to help them with some coordination, but the greatest thing is we encourage patients to do their own engagement with various stakeholders while we address the big stuff. And by also being able to create a platform for them that could help them to raise their voice. And that is also the other thing that we want to do. Yeah, it's very, very important for patients to advocate for themselves, and for the patient group only support enables. It becomes some form of a glue to help you or give you the resources, the directives, but not to do it for you. And that needs to be clear to everyone in terms of self-advocacy. Thank you.
Thank you, Samuel. And I think, that's something that resonates with your presentation yesterday, Kelly, too, in terms of recognizing, mental health as well, and that the taxing, the cost that we get emotionally involved in the individual stories as well. And it's to what extent do we need to support ourselves as much as we need to support people to advocate for themselves, but be there to help on that pathway and to elevate and give direction where needed, so that people are empowered. So yeah, thank you for that. I think I guess we don't have much longer, and I just want to look at I think some of the questions that have come through while we've been talking, we've kind of touched on. We've mentioned newborn screening, and that newborn screening is fairly negligible, non-existent. We're fighting for it across countries in the African continent, but it's a stepping stone. So, you know, it's something that we're recognizing. We've talked a little bit about awareness, some of those questions, and not acknowledged the Medics for Rare Diseases idea about education too. And I think it provided a very clear answer on that. One person has asked, where would be the best place to look for more information about the issues that African countries are facing? I'd like to ask you where would be that place, or I think maybe get in touch and have a conversation, but
I can touch on a few of them. I think Kelly has done a lot of work for the continent. And so she is the most resourced when it comes to issues of rare disease Africa, issues relating to rare diseases in Africa. And there are a couple of activities that you could get feed information. There is a global call for rare diseases in Africa, a publication on that highlights some of the issues of rare diseases in Africa. There was a meeting in 2018 and our recently held African Summit. This also gives some highlights of some of the issues, but specific countries have their own challenges as well that you want to look at as what is happening with specific countries. You can get that information by approaching the patient national patient organization. There are some crossing because we have patients from other regions reaching out to us, so it gives us a fair idea of what may be happening in their country, but that's may not be the true situation. It may be from that patient we spoke with. And so in terms of resources, that is a few. There are other groups, research groups like the A3 Africa, who is doing other researches and they have a rare disease working group. So they also have some information regarding what the research landscape may be for the rare disease situation in terms of the research. We're still talking with other groups to be involved. And so as we make headway, I think that Kelly is the best to touch on the issues of rare disease.
You've just been landed in it, Kelly. nice
push under the bus there.
But, you know,
I would
Kelly.
just like to say that it's a collaborative effort, and I think developing a universal, well, a sort of continental resource is something that we've obviously wanted to do, and we actually just need to get on and do it now. But yeah, like Sam said, we have spent quite a bit of time networking, and we've developed pretty strong coalitions, etc. But equally, the challenges are not the same universally. So you know, it is best. We all conversationalists, all of us on this call. We like to pick up the phone and have a conversation. So that's always the best first port of call.
And I'd vouch for that. I think, yeah, if you want to understand, reach out. And I know these people here are very keen to tell you their stories. Another question from the chat: how do you handle situations when a patient or a family needs help and is quite desperate, but you need to empower, not enable? I never want to feel like I'm not helping. How do you handle situations like that?
Yeah, never easy, particularly when you've walked the road as well. So you understand the emotional trauma. I think that's what makes it the hardest for us, right? None of us decided that. We didn't go study to be rare disease patient advocates. We all came here because something happened in our personal capacities and you know, threw us in this way, and we became passionate about it. But from my perspective, it's always I always ask myself, am I encouraging this patient to do something? Because I think for as long as you're encouraging them to actually make an action of any kind, you are empowering them. The minute you are asking them to give you something for you to do, I think then it's enabling. So that's kind of my guideline when I'm in a conversation and I need to, like, you know, reevaluate. That's essentially what I use.
Okay.
Thank you. Rosalind, did you want to say something?
Yeah, she has a case.
Yes. Well, so yes, it's true. And I totally, Kelly, I feel you. And sometimes you just want to fix it. You want to come in and sort them out, you know, for them. So the trouble sometimes is that you can find a family that doesn't understand medical literature very well. So what do you do then? Then you can interpret it for them and explain to them what it means. But there are two things I do on my part when I have these families, especially when it's a disease specific, you know, someone comes and it's not the same disease you are familiar with or your child or family has. So one, I always, if of course they can get online, is to check the international organization. Then you know how to manage the disease every day. That I might not be able to do it. The people, the community, the international one, because you'll have people from all over the world and they'll be able, and that has helped a lot. You find that people who have had issues, daily issues, they've gone to their doctor, the doctors don't know what's going on, but then they've seen it that it's not unique to them, that people with this condition, children with these conditions constantly have these things, and this is how they do it. So you see, it's the nicks and hacks of how to deal with that. Secondly, you find some of the international organizations will provide diagnostic, you know, they'll pay for some of the diagnosis. Let's say if it's genetic or like, sometimes you try and see if there's an international organization that can support that. So if it is genetics, they can pay for it for you just to get a confirmation or not, if this is the disease. That tends to help. At least it waivers the costs of some of the things. So that can at least keep them, you know, you've moved them to somewhere else.
Yeah.
Totally. Trudy, did you want to say something? And then I think we're just going to have to keep an eye on time. So Trudy, please.
All right. I just wanted to say, earlier I needed to put in a comment to just say, you also need to be empowered as the leader of these patient organizations. If you do not know what you're doing, you probably cause more harm than good. So when you are also aware of your limitations, how far you can go and what you can do, it helps a lot. You don't end up with a situation where you have many patients which you cannot serve. I have found that international platforms have been very useful for us, but there's still the language challenge. They're usually in English, and some families do not understand English, or they have just a little knowledge. So those translations are important for us to reach out and help those patients. But referring, I think that's the way to go to help.
And I know that you are all really good at asking for help, or just asking, like, I've got this, you know, do you know someone who could help me? And I think that's, you know, that's phenomenal as well. I think it speaks to what you're saying, Trudy, in terms of recognizing your limits and recognizing where you need to build knowledge, but also at the same time not doing everything for someone else, but just knowing I need to empower myself here a little bit as well. So, okay, so I'm really aware that we're about to run out of time, and the audience should know that we can probably continue for another couple of hours, even the rest of the day. As Kelly said, we're all conversationalists. I was going to say conservationists, but conversationalists. I really want to, you know, I've kind of said from my perspective all the things that, you know, that you have taught me in terms of advocacy and a way forward. And I know that one of the things that I admire about you is the way that you model how you want it to be done. You know, you are really true to your communities, you're true to your cultures, you're true to your countries and to your region, and that's really admirable. So I want us to all finish maybe with a really, really brief summary, and it might be that you want to share your hope, although that might feel a little bit cliched. If that's too cliche, what your reality check is, or even just, this is what advocacy for me means right now, and this is my take-home message right now. So if we could just do a round robin where we make our final statement and then go. Samuel, I can see that. I'm not sure if everyone else can see you, but we can see you. Can people still hear Samuel? Oh, there he is. Great. Who would like to start? Throwing it out there. Samuel, you go.
Yes, for me, advocacy is about change, and it's about doing, and it's about acting. And so that is what it means to me, and that influences the work we do here in Ghana.
Thank you, Samuel. Trudy.
Yes. Because I took 3 years trying to find myself, then my space, I think I eventually got there now. And I think for us right now is to identify the patients and to make it accessible for people with rare diseases to get the services that are already available, but they are not aware of and have not even had an opportunity to get. I think that's how we hope to go, and maybe that will help other patients come out from hiding to also get the help that they need. Thank you.
Thank you, Trudy. And I know you've talked about that with us a lot in terms of just feeling like you were floundering, not knowing how do I do rare disease. And sometimes it takes a while to settle in the way forward and to find those bite-sized chunks and as you say, find those patients with rare disease and how you can help. Callie.
Advocacy for me is the feeling that I got this morning when I received an email stating that we had won a legal battle that we've been trying to fight for the last 2.5 years on behalf of a 10-year-old child who tonight will go to bed, his family will go to bed with the knowledge that someone has done something to save that child's life. And there's nothing like it. It's hard, it's emotional, but moments like that are what keep you going forever.
And yeah, you'll probably reduce us all to tears right now. That's amazing. Huge kudos. Well done, because I know these fights are not a fight that happens overnight. These are long, big battles. So kudos. Christine.
For me, advocacy is, I would like to address this mostly to not the panelists, but for the listeners who are wondering how can I get to where the panelists are, is get structures so that when passion ends, there's something to keep you going when it comes to advocacy. Because you all started passionately, but we need to, passion does end, we do wear out, we're humans. So get structures and policies in place so that by the time the passion runs out, you're still going.
Thanks, Christine. Rosalind, do you want to close for us?
Wow, that's a big one, but I'll say, for me, advocacy is speaking for someone who can't or is unable to, but not ending there. Seeing that change, like in the region, we have our challenges. While you're working with the challenges, work also on changing some of those challenges, because it is possible. I know the problem is that sometimes you get caught up with what's not there than what's there to make it there, better.
Thank you. Thank you all. Once again, this has been really inspiring, and I want to thank you for sharing the stories you have, but also sharing your vision and sharing your method really with us in such powerful ways. We've talked through everything from diagnosis and what it takes to just get someone from a rural area in front of the right person to even begin the process, let alone then to be talking about awareness, to be talking about the system change that we envision, and to be talking about how do we create self-advocacy for people living with rare disease across the African continent. But thank you. I think there's so many take-home messages here. And I want to say to everyone who, especially those who have asked, how do we learn more, to reach out, because these are a group of people that you're going to want to watch this space. I think the summit that happened in Ghana last year and the meeting in 2018, you know, these have been all really instrumental, and momentum is growing. But it's not just momentum, it's just a way of doing advocacy that is incredibly powerful and impactful. So thank you all. I'm going to hand back to the Beacon team.
Hi, thank you so much, Shirlene, for hosting that session. And I want to say a massive thank you to our panelists as well. I really enjoyed hearing all about the work that you're doing and the progress and the mountains that you're moving, like Shirlene said. So massive thank you again. And I think the timing's pretty good. So I'm just going to say a massive thank you for everyone that's tuned in. I hope you enjoyed it. We have a networking session next and a few more sessions this afternoon. So check out the agenda. And yeah, I hope you enjoyed the session and have a great rest of your day. So goodbye, everyone. Thanks again.